You don't remember the people we affected?
Right. So everybody, I didn't realize everybody else was here. Did you get it recorded yet? It's just started. It just started. Okay. Yeah. All right. Welcome everybody. It's nice to see everyone here. Some Wednesdays we have our faculty meetings that run right up until this, so I apologize for that. And typically, Dr. Buchanan is here, but she's not here. But today we are really excited and happy to hear from students within EOHS who have been funded on pilot research programs through the ERC. So we are going to start with Brett. Maybe you can talk a little bit about where you are in the program, who you are, and then your research. So we're excited to have everybody here, and thanks everybody for being here.
Thanks, Kristen. Good day, everyone. Like she said, my name is Brett Shannon, and my PPRT project is on rideshare drivers' health and safety. And that's what I'm going to talk about today.
Yeah, I don't. Why is it not sharing the screen?
Good. That's okay. Before I begin, I'd just like to acknowledge the traditional owners of the land UIC is on, the Miami and Three Fires people. They're the traditional owners of the land that UIC is on, and I think it's important to pay respect to their elders, both past and present, at the start of meetings. So today, it's a 15-minute talk for each of us, so I'll just quickly talk about myself, how I got this PPRT project, a bit of background around rideshare drivers and why they're kind of an interesting group to look at, and then go through the PPRT project that we're going to roll out. So I am in my final year of my PhD in EOHS. I come from Australia. I came here a couple of years ago, and before I came here, I was working in a clinic as the occupational doctor, and our clinic saw mainly sort of mining, aviation, and construction workers, and so I would treat their injuries. But most of my work has been around Indigenous health. So in Australia, I worked with Indigenous clinics for about 14 years since I was a teenager, all the way up until moving to Chicago. This picture on the left, part of my master's thesis, we rolled out a program to provide these jerseys, football jerseys, to patients that came into the clinic if they got a health assessment. And our health assessments increased from 2,000 to 20,000. And from those health assessments, we got a 25% hit rate of a new chronic disease or new medication for them. So it was like a really good public health story, and I think kind of interesting. And yeah, now I'm doing my PhD mainly in Indigenous occupational health, and this rideshare project is kind of just a side piece that's not part of my thesis. So this bit I think is kind of interesting for students that want to do like pilot projects. So my pilot project kind of started an odd way where I had a meeting in Washington for Australians in the US. I met this guy who's an assistant professor at Johns Hopkins. He had just done a project on rideshare drivers and didn't know what to do with the data. We talked about collaborating. I got his data, and from that we made a publication. And then after talking to Preeti and Kirsten, they were doing similar work here at EOHS with the Center for Healthy Work, and we decided to put a PPRT grant in together. So I think it's just important to know, like, if you want to do a pilot project here, like, just talk to people in UIC, outside of UIC, and I think that's the easiest way to go about it. A bit of background about this workforce. Like, it's a huge workforce now, the rideshare drivers. It's really grown over the last 5 or 6 years. It kind of dipped during the pandemic, but it's really picked up again. So Uber reported around 23 million trips per day in the last quarter of 2022. Lyft records how many active drivers they have, and they had about 20 million worldwide. It's a massive workforce now. We had a meeting with the city of Chicago 2 weeks ago, I think, and they said you have to be registered with the city to be a rideshare driver here in Chicago. Correct me if I'm wrong, Ron, but I think she said they have about 100,000 people registered, and about 50,000 of those are actually active drivers. So you wouldn't think that many in just like one location, and that's a huge workforce that we really don't know a lot about. And what's interesting about this workforce is, unlike commercial cargo drivers and other drivers, they're independent contractors. So this means that they don't get workers' compensation, they don't get paid sick leave, and they have really irregular work arrangements that puts them at risk in a lot of different ways. And what's interesting here in the US is this was actually brought up in California under Proposition 22, where they deemed it illegal to have rideshare drivers as independent contractors in February. And then I think it went up the courts and it was reversed that it isn't illegal. So it's a contentious issue at the moment that's coming up in a lot of states. Most of the research and information to date around the rideshare workforce has been to do with motor vehicle crashes. And this is kind of because of two reasons. One is like motor vehicle crashes are the biggest cause of work-related deaths in the US and most other countries. So very important to do a lot of prevention work in that area. And the second is most of the data we have on drivers is just crash data. We don't have a lot of driver level data or other data. So a lot of researchers are just using crash data to get more information about rideshare drivers. And the literature to date has been kind of mixed, to be honest. On the one side, there's been a lot of literature published around alcohol-related crashes and how they've reduced since rideshares come on board. And then the other side of it is a lot of researchers are saying we're going to see an increased incidence in crashes because of poor safety behaviors across rideshare drivers' workforce. But a lot of these studies, it's very limited data. There's a lot of assumptions being made. So it's sort of a growing area that we're learning more about each year. And to date, there's really been little information about minor injuries in drivers or any morbidity. A lot of it's been around mortality data because that's what we have the best data on. Other literature that's come out in the last sort of 2 to 3 years has been around risky passenger behavior and safety behaviors in general with drivers. The lack of policies that we talked about them being independent contractors and how we can work towards better policies for drivers. Economic pressures and concerns. When you think about these drivers, time is money and how that influences your safety behaviors and your driving risk. COVID-19 infection, a lot of studies out of sort of Washington State around COVID risk in rideshare drivers and safety behaviors during the pandemic. And then sleep deprivation and fatigue. If you think about all other safety critical workers, we usually cap how many hours they can work a day, how many breaks they need. Whereas this workforce, we really don't do that at all. And talking to workers, you can switch between providers. So you can do a 10-hour shift with Uber and then go to Lyft and vice versa. So there's a lot of risk around fatigue and driving. And then acute musculoskeletal pain. I thought this was interesting. This researcher in Florida actually got in like 40 Ubers in 4 days and just did a survey with each driver looking at musculoskeletal pain. But these are sort of the lengths people are going just to get any data on rideshare drivers. Because they're independent contractors, it makes it just really tricky to use them in any research that's valid. This study I just found this morning, and I thought it was kind of interesting to share. So Chinese researchers actually have the company level data in terms of the star rating of drivers, how many hours they're driving for, all the data that you would expect Uber to have. And they also have crash level data. So they use Poisson generalized additive models because they're nonlinear models to look at each risk factor and compare it to the log risk of having a crash. So you can see the far left one, they looked at the passenger rating for the driver. And you can see once it gets sort of past 4.5, the risk dramatically drops, which is what you'd expect. If they got a bad rating, they're going to be probably at higher risk of a crash. The second one is years being a ride-hailing driver. So you can see as their tenure of being a driver increases, the crash risk goes down. And this one was kind of interesting. So they looked at what percentage of shifts drivers were doing as long shifts. and they classed a long shift as over 12 hours. So you can see if they're doing sort of around 40 to 60% of their shifts as long shifts, the crash risk increased, and then it kind of dips back down if all their shifts are long shifts, which kind of makes sense as well. If they have a lot of experience and that's what they do regularly, then the crash risk might reduce as well. Just an interesting paper. So back to the John Hopkins Australian that I met with in Washington, he gave me his data. They did a pilot survey on around 300 rideshare drivers in the US. He was focused on child safety, so child seats in rideshare cars, but I kind of looked at the data from a different point of view and found that 1/3 of the drivers had actually been in a crash. And then we looked at risk factors associated with the crashes, and it was similar to all the other data, really. So risky safety behaviors, driving on unfamiliar roads, not offering certain things to passengers, such as childcare seats. And we actually got a publication out of this, and that sort of led to developing this further PPRT project. After looking through this data, I came up with lots of different areas that I'd like to look at in a further survey that I started using in developing the PPRT survey. And then Ron and I went to the Independent Drivers Guild, what would you call it, family day. Yeah. We talked to a lot of drivers, kind of cut off down the bottom here, but this square box down the bottom is things they talked about and things I hadn't thought of. Things like a lot of them are getting calls for women in labor, and there's actually papers now on rideshare drivers being used instead of ambulances to bring women in labor to the hospital and the implications that has. Lots of questions around income, wages, work arrangements, insurance policies, and then things like that you wouldn't even think of if a passenger says something about a driver. In some instances, they talked about being taken off the app for 7 days without rebuttal. So they just lost work for 7 days and they can't even answer back. So things like that were really interesting just to get the driver's viewpoint on. So now I'll just talk about the PPRT project quickly. How are we for time, Badisha? Okay. So this project now, after doing all of that work, the aim is to develop a large survey that adapts questions from various different surveys and constructions and tools to specifically characterize all of these employment arrangements, conditions, health and safety issues in rideshare drivers. And then we want to explore these arrangements and these different health and safety factors by age, gender, race and ethnicity, location, and multiple other demographic factors. How we're going to do this is we've already undertaken a systematic review. We've collated a lot of different survey instruments and put them together and categorized to develop constructs that we can use. And then we're going to do an initial cognitive testing of that survey. And this is really about step-by-step going through the survey with different drivers, looking at how they read a question, how they respond to a question, and how they comprehend the survey responses. And then we'll roll this pilot survey out. We have a few partnering organizations, and hopefully we'll be able to do it with the city of Chicago. When a driver registers with the city, they actually get their contact details. So we're hoping that they let us use that listserv to roll out the survey. And most of the PPRT money we're using, or nearly all of it, is to do with gift cards for drivers to complete the survey. It's a large survey, so it's going to take a lot of their time. At the moment, I have 76 questions in all these different fields. So we're going to pay drivers $30 to $50 to undertake the survey or use gift cards in that range. And I think this is going to be a really great project because there's a huge gap in our understanding of this workforce, like I just touched on. This survey will look at so many different areas that we can hopefully do further work in to improve the health and safety for rideshare drivers. And really develop some system level changes where we can develop training packages and inform some policies around health and safety with the city. But I think that's about my time up. Yeah, that's all I had to say. And I think Lapita is next, or Chibzil.
or while you're switching out, does anybody have questions for Brett and his work?
I can go.
I have a quick question. Yeah, thank you so much. That's really interesting. I guess the slide where it talks about like the alcohol use and accidents, I'm curious. So you said there were like conflicting reports. So does that mean there's certain studies that show that there is a correlation between like alcohol use and accidents?
Conflicting reports in that they're associating drops in crashes that had alcohol involved an increase in rideshare driving. But obviously there's lots of factors the last couple of years, like the pandemic. We saw changes in driving behaviors and closing pubs and clubs. So that decreased the risk as well. So really just associations rather than causation.
You have to make it full screen.
And a lot of assumptions in that data. And then some data, they grouped 4 states down south. I think it's Texas and a few others, and they showed an increase in crashes overall and correlation with rideshare driving. So, yeah, no hard facts is sort of what I got from it anyway. If that makes sense.
Question, those who have taken up the profession have left some earlier with students. Are they satisfied? Or not? So they want to go back.
Yeah, that's what we don't know. And what's interesting about if we can use the city of Chicago, we've actually developed surveys for people that have left rideshare driving, people that do it part-time, and then people that do it full-time, because I want to know that question. The answer to that question is really, why are you doing this? Either part-time or full-time, why did you leave it? And sort of understand if there is pathways to other jobs for them as well.
Someone wants to do this irrespective.
Yeah, exactly. Because some did, and we actually asked some drivers at the meeting, last month, 2 months ago, and some love it, some do it full-time. But others are just trying to find a job
This is
and
not the
do it to pay them.
No, it's okay. I sent you the update outline. After that. It's okay.
Definitely, there's kind of 2 sides of it. One, people complain because the best hours are not ideal and that they're sort of the evenings, early mornings on weekends. But the other, people do love that, particularly the full-time drivers. They try and just do their 60 hours, they pick and choose. So yeah, I think it's different for each group. Yeah.
Can everyone hear me okay? Awesome. My name is Chibuza, and I'm a postdoctoral research associate with Lee Friedman here in EOHS. So this should say public safety workers. Sorry, it's a typo. And I will be talking about my PPRT grant, looking at risk factors of cardiovascular disease in public safety workers. So this is an outline of my presentation today. I would quickly go over the background and why this study is important. And then I'll go over the population, what we're interested in looking at, and then some of our analytical strategy. So I really got interested in occupational health. I am originally from Nigeria, and I trained as a physical therapist, where I was involved in clinics, working with different occupations, different types of chronic diseases. And then I moved to UIC and got my MPH and PhD in epidemiology. And I've worked with Lee Friedman, looking at surveillance of different chronic diseases among different occupations. And so that has really progressed into looking at specific occupations where you have higher burden of some of these diseases. Also, so thinking about occupations like public safety workers, thinking about farm workers, things like that. So cardiovascular disease is really a group of diseases like stroke, heart attack, and it is the #1 killer in the world. And there are several risk factors that are related to this disease, like high cholesterol, high blood pressure, but occupation has not really been looked at as one of the main risk factors. And some studies have shown that there are really disparities among different occupations when you think about CVD. And so we were really interested in public safety workers. So you can think of law enforcement officers, firefighters, EMS officers. You can think of correction officers. So those would be your public safety workers. And these workers are involved in everyday emergency response. So you get a 911 call, they have to go out there. If there's a fire, they have to go out there. And they're really exposed to a lot of different things. And so outside of the regular exposures that other workers have, you have this added pressure for public safety workers. And so you can also think about sleep. A lot of them have nighttime shifts where they have to work through the night. And this really affects all the other cardiovascular risk factors and increases the risk of CVD among these workers. And when you think about all of the risk factors, you can think about the workplace risk factors that these workers cannot change, like their shift time. And you can also think about risk factors like smoking that are more individual, and really thinking about how all these risk factors come together to increase the risk of CVD. So this is really a diagram of some of the factors we're interested in. So thinking about lifestyle factors like smoking, alcohol use, physical activity, thinking about all the various clinical factors that I mentioned before that are related to CVD, like hypertension, diabetes, high cholesterol, and then really thinking about the specific occupational factors that may increase the risk of CVD. And then also thinking about like workplace health interventions. I would talk a bit about that in the coming slides and how that affects these risk factors and the prevalence of CVD. So in preparing this grant, we had looked and found that a lot of the studies had really focused on either firefighters or law enforcement officers and were very local in their scope. And so we wanted to really see what the prevalence of CVD was in public safety workers at a national level and in different regions in the US. So we were also interested in, again, like I mentioned before, the factors that are related to CVD among these workers. And then we know that NHIS has collected some questions on occupation. We were interested in how these occupational factors were also related to CVD. And then we were interested in looking at how factors like lifestyle and clinical factors were modified, or how they mediate the relationship between these workplace interventions and the prevalence of CVD. So you can think about how, for example, this affects like the choice of smoking or your blood pressure and how that affects CVD. So to conduct this study, we are using the National Health Interview Survey from 2008 to 2018. And because this is among public safety workers, which are all supposed to be adults, we're only focusing on the adult data files. And then we're also using the Occupational Health Supplement, which was a survey that was conducted in 2010 and 2015 to really get at more occupational questions. And then this is really a table looking at some of the demographic characteristics of public safety workers from this data set. And then to really identify public safety workers, in this survey, they're called protective service occupations. We're using codes from the occupational classification codes to really identify these workers. So we will be looking at 5 CVD outcomes, and then a sum of all the outcomes, which forms the total CVD. One of the things with NHIS is that they use a self-reported physician diagnosis of CVD. So these workers will ask questions like, have you ever been told by a doctor that you have heart attack, that you have stroke or heart condition? And so we do not have any access to ICD code in which you get if from electronic medical records. We do not have access to an MRI or any of the tests that are used to diagnose CVD. So this is one of the limitations of this database. These are some of the occupational risk factors that we're interested in. So for the 2008 to 2018 database, we're interested in the duration of employment. So how long have they worked and how does that affect their prevalence of CVD? For the occupational health supplements, we are interested in different questions, like their work schedule, how many times they had a nighttime shift, whether they were exposed to workplace chemicals, to secondhand tobacco smoke, things like that. And then one study had looked at workplace stress, and they had created a score using multiple variables from another paper looking at a different workforce. And so we are also interested in using these variables to get at workplace stress in this population. And then these are some of the non-occupational risk factors. So you have your demographic factors, you have some of the clinical factors, and the lifestyle factors that I mentioned before. And then finally, we were interested in getting at how knowledge of CVD symptoms, how that affects the prevalence of CVD. So NHIS had collected this question asking participants how much they knew about CVD symptoms. And in reading the literature, there have been some papers that have recommended more education on symptoms. And so we were really interested in seeing whether this has even worked at all on a national scale. And then NHIS had also collected questions related to workplace interventions, like whether a physician at work or occupational physician had recommended different lifestyle changes, whether you had an access to a gym facility, things like that, and whether there was screening available at the workplace. So we're interested in seeing how these variables were related to CVD and how they affect all the different lifestyle factors that I had mentioned before. So the next steps for this project, we're working on the data analysis. So we would run descriptive and multivariable models to really answer all of the questions that I've mentioned. And then we will use a structural equation model for the mediation analysis. And for future research, in some of what we've worked on in writing the grant, it will be really interesting to focus on specific public safety workers. A lot of the studies have looked at firefighters. There's rarely any studies looking at emergency medical services. There's a few looking at police officers, but almost none in correction officers. So based on our findings, we're thinking of future studies that will sort of address that. And a lot of the studies, again, have, like we're doing, use self-reported physician diagnosis. So we're thinking of leveraging electronic health records and ICD codes to really make sure that all of the cases that we're finding are really CVD cases. And then some of the policy implications. By the time we're done with the analysis, we should have an idea on how well all the workplace interventions that were collected by NHIS, whether they actually had any effect on the prevalence of CVD. I know there's been some talk on having firefighters and police officers retire before they're 60, just thinking about all the cumulative effect of their work. But I don't know that most states have passed policies like that. So thinking about, based on our findings, how we can sort of form some policy, push some policy forward. And that's it. If you have any questions, you can contact Brett, myself, or Lee. Shoot us an email if you're interested in any of this work. Thank you.
Any questions? I don't think there are any in the chat. I'm just trying to make sure.
Sorry.
No, that's good. Before you get going, do you want to try not to talk about the chat thing?
Yeah.
Press on the board. There you go. Okay, perfect. Got it. Is this too high? I mean, it's okay. It's fine. I'll try to move around. Okay, so hi everyone. I'm Lupita. I'm a fifth year PhD student in EOHS. And today I'll be talking to you about my research and on pesticides and pesticide-related illness and surveillance in the state of Illinois. So this is just my outline. I do have a lot more slides than I will cover today for the time being to save some time. So I'll skim through aims 1 and 2 because I wanted to include them because they lead me to aim 3, which is what my PPR funding is for. So if you have any questions about anything I skip, you can let me know. So just briefly about how I got here. So I actually started with infectious disease interest in college. So I had my Bachelor of Science in cell molecular bio. I studied parasitology and I had my first publication there, which cemented my love for research and it led me to get my global health degree. Where I also studied parasites and the gut microbiome in children. I spent 2 months in India collecting data. And that's where I realized that although we were providing all these deworming medications, anti-helminths, we had great programs, we weren't really addressing the social determinants of health. So we were seeing a lot of environmental influences, like where people got their water and where they lived. So from there, I became a clinical research coordinator. I worked there for almost 4 years at the Safety Net Hospital in Arizona, which is where I'm from. I worked with the OBGYN and refugee clinic conducting studies, which also opened my eyes to the importance of occupational health, because a lot of women that were coming into the clinic were highly influenced by their work and also the political determinants of health in which they lived. And so this led me to here to study environmental and occupational health, where I'm currently focused on pesticides, pesticide exposures, farm workers, and IH. So just a brief background on pesticides. As we all know, they're substances used to kill a variety of pests. They can be both biological and chemical, with the latter being the most toxic to humans. And they're very abundant and ubiquitous. Nearly 1 billion pounds are reportedly used in the US every year, with 90% of that being mostly used in agriculture. And there are 2 main types of pesticides that we like to focus on. There's structural and agricultural. So structural are the ones that you see being applied around buildings and parks, urban areas. And then the agricultural ones are the ones that they call restricted, which are the ones obviously used in crops and farms. And both of these types of pesticides require a special type of licensing to be able to be applied. And just to give you an idea of where those agricultural pesticides are applied. So corn and soybeans take the brunt of the use of pesticides. And who is the number 1 and number 2 producer of corn and soybeans? It's Illinois. And then just briefly, of course, there's so many different ways you can be exposed to pesticides. There's different activities, different settings, and it can occur via skin absorption, inhalation, ingestion. And not only in the field, but also at home as well, if you have pesticides at home. So PRI, or pesticide-related illness, is what we refer to any acute or chronic health effect because of a pesticide exposure. And the signs and symptoms can vary widely from any mild skin irritation, upper respiratory irritation, to more chronic health effects like neurological effects, asthma,
cancer, and even sometimes death in very, very serious situations. And then just to go briefly over regulation. So because of their potential to cause harm, they are highly regulated. So at the federal level, they're regulated by FIFRA, or the Federal Insecticide, Fungicide, Rodenticide Act under the EPA. And this has been established since 1947. They oversee the regulation of the registration, distribution, use, sale of all the pesticides in the US. And then OSHA here in Illinois is not very involved with pesticides because, and then agriculture has a lot of exemptions as well, but there are around 72,000 farms. Most of them are family, small farms. So as we know, OSHA only oversees anything with over 10 workers. And then we don't have enough officers to evaluate all these farms that we have. So hardly ever are they involved. Illinois Department of Ag, pretty much they license those restricted use pesticides. So if you want to apply pesticides in agriculture, you go through them to get your license. And then on the other hand, IDPH focuses more on those structural pesticide applicators. So again, states that rely heavily on agriculture tend to suffer greater risks of pesticide exposure. Illinois is the 5th largest agriculture state, and like as we mentioned earlier, we have the dominating crops that are soybeans and corn, which demand a heavy use of pesticides. But what is the problem? What got me interested in this? Well, despite pesticides being highly regulated, we continue to see patterns and serious cases of pesticide poisoning among farm workers. So in 2019, we had a very serious case of a helicopter spraying pesticides on some migrant workers in central Illinois. They were all clearly wearing visible orange clothing, hats. They were supposed to be on the field, but they were sprayed. And then 2 weeks later, they were sprayed again twice within half an hour. And a lot of these migrant workers included teenagers, workers in their 60s, pregnant women, and a lot of them ended up in the hospital. The applicators were only fined $750, and they argue that they were not legally responsible for any injuries they caused to these workers. We learned about it at UIC because we were contacted by various agencies with questions, but there really wasn't a streamlined approach to this and how to report, especially one that would benefit workers in a timely manner, and to also capture more information on how the exposure occurred. So why is surveillance important? Well, monitoring and reporting injuries and illnesses is critical to adjusting any failures in legislation and to protect humans and identify gaps. States that are like huge agricultural states like California and Michigan do have comprehensive pesticide surveillance programs in place. Through mandatory reporting, follow-backs, communication among agencies and organizations, they're able to capture these cases, and then annually they have reports, and then they conduct evaluations. Illinois doesn't have anything like that. So my project focuses on making the case for something like legislation to be applied here. We also have the NIOSH sensor program, which maintains, it's a program to help states build and maintain occupational illness and injury surveillance capacity, including pesticides. Typically, censor states that have legislation in place have stricter fines, they have ongoing recommendations. Illinois, although it's here in this list, we do receive some funding, but we don't have any legislation. So everything we do is because here at SPH, we do receive some funding and we count some cases through databases that we have, but it's not comprehensive like the states that have actually something in the law. And I was able to go last year to the EPA headquarters and met with these states. And I learned a lot about how they conduct their surveillance programs, what works, what doesn't. And I used this to develop a model for Illinois. So this was very informative for me. But currently, if we don't have a system, where do we start? So we just look at what we have available, like the Poison Center and hospital data. But again, if these processes aren't in place specifically to capture these cases, then you're gonna miss a lot of information about exposure and especially about occupational history. And of course, there's a lot of also other qualitative barriers and issues related to capturing cases. So just a brief overview of all my aims. So my first one is, okay, we don't have anything in place. What can we do to count cases? What we have. So I used hospital data and the Illinois Poison Center to count wherever cases would be captured currently, and then describe that. I used a multivariable analysis as well to get the odds ratio of like people and risk factors of people exposed to pesticides and what are the risks of like ending up in the hospital. So this kind of helped me see what we have in place and also any gaps in what we're missing in the information to kind of help me guide that model that I built. And I'm not going to go through this for the sake of time, but we do have results. And mainly what we found is basically that there's almost no information in occupational exposures or agricultural cases. So this is my model. I don't know if it looks kind of weird, but mainly it's a central repository where all the cases come through. And then we have healthcare providers and employers become mandatory reporters. And everybody basically just reports to this one repository. And then the data can then be disseminated to different agencies to evaluate, and whatever their fiscal responsibilities are, they can take action on this. So then the aim 2, now based on that model, would be to ask state agencies and NGOs their perceptions on it. So how they feel about the strengths and weaknesses of the model, the logistics of applying this in the state in which they conduct their work. And this would be done through semi-structured interviews. And it's not complete, but I've already started this as well. And just more information about the participants. I would just want to get through to my aim 3. So aim 3 here is what I requested my PPRT funding for. And this would be to understand the facilitators and barriers of reporting PRI among farm workers. So here I would be conducting interviews with the farm workers themselves, especially migrant workers who come to Illinois every year. They're usually the same people that come. So they come during the summer and then they leave around fall. And then again, they continue to come every year. And they are important because they provide that ground up approach. So if you don't involve the people that you are forming something for, then how do we know it's going to work and how they're going to use it? And then also just understand better the barriers that they face to reporting so that we can address that prior to implementing something. So again, how do the sociocultural, political, occupational, and other qualitative factors influence the utilization of this proposed model? Are they going to use it? Is it beneficial for them? Etc. So my goal is to interview at least 40 farm workers. And I'm currently doing that right now, both in English and Spanish, 45-minute interviews. And then how does that differ from aim 2? Again, aim 2 is more of those key informants, the people in place whose work involves pesticide regulation. So more from like the top down, how can we establish this in Illinois? And then the farm workers would do the ground up approach of providing that scope of and knowledge of those barriers. So it's kind of both these aims are inclusive and cohesive of the model. And this is just how I'm gonna be using my funding. It's mostly gonna go towards stipends for farm workers for their time. And then I'm also looking to hire a research assistant to help with the qualitative coding analysis of these interviews. So if anybody speaks Spanish and has done qualitative coding, talk to me. And then also to cover software and miscellaneous expenses like travel, since we have to go to rural areas of Illinois. So I hope this was informative. And if you get a chance, apply for this or any grants that you see. Anything helps, and it's going to save you a lot of time and money and get you through with your research. So yeah, thank you. Sorry, I can't see you.
So thank you so much. That sounds like a really cool project. At the beginning, you'd mentioned how everyone got sprayed and it got reported through an agency. If it doesn't, for whatever reason, like fear of retribution, have there been instances where like people post on social media or some other outlet about it and you can find out through there, or does it really just have to be officially reported?
So a really good way to find out about these cases is through news reports. So if they don't go to the hospital or they don't report it, they'll usually, so like legal aid and then the migrant council, which are legal assistant organizations for farm workers, they work with them, and that's how this information gets disseminated. But yeah, so there isn't really like this mandatory or like central agency to report to. Like UIC found out because we work a lot with farm workers, but the media is very good with, especially with the most severe cases. Yeah, for when there's nothing in place. Yes, sorry, I'm short.
Thanks for sharing all this. I saw your figure about the different crops, and so based on work I did a long time ago when I was working with the state farm in Wisconsin, we were also trying to figure out this issue of pesticide surveillance and potential for population exposure. And one thing was sort of trying to backwards calculate potential exposure based on the types of crops, because we know that certain farmers with certain crops, like certain mixtures of pesticides, then sort of also alter the risks. So have you thought about also in working with your workers to understand which crops they're working with and how long they're out in the field, the other components of that?
Yeah, so most of these farmers, they don't work with one crop. So in like one season, they'll work with like 2 or 3. So I will capture that in my survey with my interview. And I'm not sure. So my questions are formulated to get their knowledge about pesticides, their use. But that is also something that I kind of want to work in there, because the different crops do have different risk factors, right?
Yeah.
And also different types of pesticides applied. They also, and then the other challenge is that they move from farm to farm, so their employer in one farm is different than another. So there are all these other things that to consider, but yes, you got all these considerations.
Great, and so Lupita's in her 5th year, but the ag center is not going away. So there's lots of fun, and you need to graduate. But I mean, if you're interested in this topic, I think it's really important. And again, this was a long time ago, but the data that I was using in Wisconsin was this pesticide reporting that was required by federally mandated that each farmer reported to crops, or the pesticide that was using by crop. And that law went away. So there's also a lot of importance for maintaining and understanding the impacts of farm workers to potentially get some of funding back from maintaining some of these sort of like federal surveillance and stuff. Yeah, that's certainly really important.
Yeah, farmers also need help because, you know, everybody's like focusing on the farm workers, but farmers are also needing the support to have this information and share it and apply it and protect our farmers as well. Yeah, great.
Thank you.
Thanks.
Okay, so everybody, thanks for coming. This is the end of the presentation today. Thank